scan on the right. And this is an actual patient that we did 2 years ago when, as a senior resident, we did an anatropic nephrolithotomy on the patient. Okay, so for the epidemiology of your urolithiasis, the lifetime prevalence is 1 to 15% depending on age, gender, geographic location. Men daw yung mas madami, but the gap is narrowing. And for the race, most common pa rin are Caucasians. The age, usually around 4 to 6 decades na diagnose, and geographically, it's seen on the hot, arid, and dry climates. And for the occupation, kung may heat exposure or sedentary lifestyle, increased risk. And for the stone disease correlates, kung obese ka, diabetic with a metabolic syndrome, high BMI, and increased weight with CV disease, increased risk ka. I will be discussing each as we go along. So for the theories of stone formation, of course, we should talk about, again, the terminologies, the basics. So we have here the term metastable. This is a period of saturation, but still no crystallization happens. Why? Because the presence of your inhibitors. That despite concentration products of stone-forming salts exceed that of the solubility product, the crystallization does not occur. Why? Because of the presence of your inhibitors. So let's talk about saturated versus supersaturated. What's the difference? Pag saturated, point at which no further added crystals will dissolve. Ngayon, at this point, it is metastable pag walang salts or walang crystals na napoform. But if it's supersaturated, here, stone-forming salts precipitate na sila out of the solution, forming crystals or nuclei. And this concentration is now called the formation product. Again, urine must be supersaturated in order for stones to form. But again, it doesn't necessarily mean na pag supersaturated in urine, may crystals ka. Kasi hanggat meron kang inhibitors, there would be no crystal formation. So for the formation product is a product of your supersaturated concentration. When additional salt is added, it cannot be held in solution, it precipitates and the crystals form. So for the matrix, this is the non-crystalline component of stones. It is composed of mucoproteins, proteins, and carbohydrates. So in this image and table, we can see the inhibitors and the promoters. The inhibitors that inhibit crystal growth are citrate because it complexes with calcium. So as citrate complexes with calcium, calcium can no longer attach to your oxalate and hence forming a soluble product that can be excreted, which is calcium citrate. Again, for magnesium, the same lang din, o it complexes naman with oxalate. And for the others, pyrophosphate and zinc. And the one that inhibits crystal aggregation are your glycosaminoglycans and your tamorsol protein. And for the promoters are the following. Note that for the promoters, it's bacterial infection, usually may obstruction, may stasis, and of course, magkakaroon ng metabolic abnormalities kung meron ka mga anatomic problems. So if there's an imbalance between inhibitors or promoters, meaning kung occupied lahat ng inhibitors mo na or nagamit na sila lahat, and yung promoters mo naman are also there, in that we tilt the balance and then stones form. So for the simplified explanation, so we have here a saturated solution which can then be supersaturated, where the formation product occurs and then nucleation, crystal growth and aggregation, crystal retention, and stone formation. So hindi ko na discuss dito with regards to the stones is that minsan may part ng formation product mo, yung Randall plaques, nag-attach yung mga plaques na to your basement membrane of your thin loop of Henle, and then yun yung important nidus for the calcium oxalate to form. So yun yung Randall plaques. So for the classification of nephrolithiasis, for the frequency, ang most common pa rin na stone is your urinary calculi. 60% is composed of your calcium oxalate of the calcium, and 20% is mixed, and 2% is brucite or your pure calcium phosphate. For the other stones na non-calcium, 7% ng uric acid, 7% ng struvite, 1% ng cysteine, and less than 1% yung mga triamethylene silica, which are your drug-induced stones. So with regards to opacity and lucency, yung mga radiopaque natin, of course, the calcium oxalates and the calcium phosphates. And for the poor radio opacity are your magnesium ammonium phosphate, apatite, and cysteine. Mind you, yung magnesium ammonium phosphate is their staghorn calculus. Usually kasi it's not purely magnesium ammonium phosphate. It can be also aggregated or complex with your calcium oxalate. That's why it turns radiopaque on scan. And of course, if it's relatively big, you can also see the stone itself. Also, we have the apatite, the cysteine, and for the radiolucent, yung most common tinatanong is your indinavir stones, which are antiretroviral agent, and then also your uric acid, ammonium urate, and your xanthine. So for the crystal type and shape, this is also asked in the in-service exam for the basics. Yung calcium oxalate monohydrate, note the image on the right pala, calcium oxalate monohydrate, dumbbell shape siya. Pag envelope shape, calcium oxalate dihydrate. If it's flat or web shape or prisms, it's calcium phosphate. Pag struvite, coffin lid. So may ano dito, may tag dito, palatandaan ko dito coffin lid since pag struvite stone is also your infectious stone and increased risk ka na magka-sepsis, meron din chance na magkaroon ng mortality. So parang coffin lid siya, may parang coffin. Pag uric acid is rhomboid and for cysteine is hexagonal. Ang palatandaan ko naman sa cysteine is that six sides, so hexagon, 16. So for the calcium stones, is defined first. Let's define hypercalciuria. Hypercalciuria is the more than 200 milligrams per day na na calcium in your urine. This is the most common abnormality in calcium stones. But before we talk about the calcium stones, let's talk about calcium metabolism. So for the mineral metabolism of calcium, 40% absorbed in the small, in the intestines, 30% sa small, 10% sa large. Tandaan nito, yung increased calcium diet at saka low calcium diet. Pag increase yung calcium diet, manaming nakain na calcium, non-saturable siya. But it's still a minor pathway. Pag low calcium diet naman, dito na-activate si vitamin D. Pan-activate si vitamin D through your skin, to the kidney, to the liver, which I'll discuss maya-maya. This is the major pathway. This is downregulated by a diet replete in calcium. Note that calcium in ionic state is absorbed and complex is only partially absorbed. So for the vitamin D, this is the most potent stimulator for intestinal lang, intestinal calcium absorption. Kasi dun sa bone natin tsaka kidney, ang responsible doon is your PTH. So for this, it's formed in the skin where 7-dehydrocholesterol is converted to pre-vitamin D3 by sunlight, and then liver, D3 hydroxylated to 25-OH-D3, and then in a kidney, proximal tubule, ito yung nagko-contain ng 1-alpha hydroxylase. That's why it's converted and hydroxylated to your 125 D3. This is stimulated by your parathyroid hormone and hypophosphatemia. Your parathyroid hormone is for the parathyroid gland. Most potent for its release is the decreased serum calcium. Sa bone, it stimulates resorption by the action of the osteoclast. Pag kidney naman, renal reabsorption. So first, ano bang pathology natin sa hypercalciuria? Ang una nating pag-usapan is the absorptive type, hypercalciuria. Pag increase ang diet mo, meaning it's not saturable, yun din yung ini-excrete ng kidney mo. So if you have increased intestinal absorption of calcium, this then leads to renal filtration. High calcium concentration leads to increased saturation of calcium salts and reduced urinary inhibitor activity. Nare-reduce sila because calcium already complexes with the inhibitors and then nare-replete, nadideplete yung mga inhibitors mo, causing the formation of your calcium stones. And high, ang ano nito, ang tawag dito, when you work up the patient, usually high urinary calcium with normal serum calcium. Because increasing intestinal absorption of calcium is matched by enhanced renal calcium excision. Nandito yung homeostasis ng katawan natin. So, yun. So, next is your renal leak hypercalciuria. Ito naman, may impaired renal tubular reabsorption. Normally, sa 70% of the reabsorption happens in the PCT. But sometimes, the distal renal tubule calcium, nagli-leak sila sa distal tubules. If you work up the patient with renal leak, you would see high urinary calcium, hypercalciuria, with normal serum calcium. Increase in intestinal absorption of calcium and bone resorption as a result of the increase in your parathyroid hormone. If you have mild elevation of intact parathyroid hormone caused by secondary hyperparathyroidism, the characteristic is fasting high urinary calcium with normal serum calcium. Usually, ang treatment dito or the drug of choice is your thiazides and your potassium supplementation. So for the resorptive hypercalciuria, this is primary hyperparathyroidism, usually caused by a parathyroid adenoma. There would be an increase in your parathyroid hormone causing excessive bone resorption and increased renal synthesis of 125. Yung 1-alpha-hydroxylase activity na kidney mo, increase, causing an increase in your vitamin D and hence increased na yung intestinal absorption of calcium. Ang workup naman dito is usually would see a high urinary calcium with high serum calcium and reduced phosphorus levels. And the hallmark is increased urinary calcium during all calcium diet manipulation dahil hyper or grabe yung effect ng parathyroid adenoma. So the treatment of choice is you remove the parathyroids and you give bisphosphonates para ma-decrease ang osteoclast activity. So how to differentiate the three? So here we have a table differentiating the three. So memorize nyo na lang yan. For the other causes of hypercalciuria, if the patient has sarcoid or granulomatous disease, production of your activated or your active vitamin D from 1-alpha-hydroxylase are present in the macrophage of the sarcoid granuloma. Hence, magkakaroon ng increase ngayon ng intestinal absorption of calcium causing hypercalcemia and then your hypercalciuria. The treatment is corticosteroids. Also, pag malignancy hypercalcemia. Ang tatandaan ninyo, the most common cause of hypercalcemia in inpatient is still malignancy associated. 60% is found in the lungs and the breast, 10 to 15% renal cell, and 10% head and neck, and 10% hematologic. Pag OPD setting naman, ang most common cause ng hypercalcemia is still primary hyperparathyroidism. For your glucocorticoid-induced hypercalcemia, ang effect ng glucocorticoid mo pag umiinom ka nito ay bone damage. Magkakaroon ka ng bone resorption, reduced bone formation, leading to osteopenia. Tapos nun, also, if you give glucocorticoids for patient with sarcoid disease, pwede rin magkaroon siya ng glucocorticoid-induced hypercalcemia. So you need to balance it also. So next, we will discuss is hyperoxaluria. So this is urine oxalate of more than 40 milligrams per day. So first pathology is your primary hyperoxaluria. Ito, hepatic enzyme deficiency, which is autosomal recessive. And hence, kung mataas ang oxalate mo, mas marami magko-complex sa calcium. Usually, ang patient is a pediatric patient with renal and hepatic failure. So, ito yung most common deficiency. So, yung 1-AGT, alanine, glyoxylate, aminotransferase, with pyridoxine or vitamin B6 as an important cofactor. Here, your glyoxylate conversion to your glycine is prevented, so may kakaroon ng preferential oxidation ng glyoxylate to oxalate. If there's an increased oxalate, mas marami magko-complex sa calcium, magkakaroon ka ng calcium oxalate. So the treatment is combined renal liver transplant plus pyridoxine supplementation. Next is your enteric or intestinal malabsorptive state. The most common cause of acquired hyperoxaluria. Yung ma-associate dito yung mga problem sa intestines. Ang explanation dito is that if you have the following, mga malabsorption, chronic PANC, if you have fat malabsorption, magkakaroon ng saponification of fatty acids with divalent cations, calcium and magnesium. And then there would be a reduced calcium oxalate complication. Hence, more free oxalate available for saturation, causing an oxalate stone. Also, this is also seen in your chronic antibiotics for cystic fibrosis. Dahil pag uminom ka antibiotics, may possibility to decrease the oxalobacter formigenes, which is important for the degradation of oxalate. Ang treatment dito is probiotics to increase the bacteria. Also, for the treatment, You can give calcium magnesium gluconate supplementation to decrease the saponification with fatty acids. You can also give cholestyramine to bind the bile salts, and also you need to increase the pH. If you increase the pH, you increase also the citrate and also high fluid intake. Next, diet hyperoxaluria. Ito yung mga diet rich in oxalate. Katulad ng lemon, rhubarb, spinach, okra. Pag sobrang dami mo kinain, you have a high oxalate diet. More oxalate to complex with calcium. Also, ito, tinanong ko before sa in-service sa basics, if you increase or na-overdose ang vitamin C, it can then lead to hyperoxaluria. Also, if you have decreased in calcium intake, there will be decreased oxalate complex and increased oxalate absorption. Hence, magkakaroon ka ng diet hyperoxaluria. Next is your idiopathic. This is seen in certain populations, but this is relatively rare. Meron na abnormalities in the metabolism and transport of oxalate. So treatment, low oxalate and pyridoxine supplement as your cofactor. Next is hyperuricasuria, is the urine production of more than 600 milligrams of urinary uric acid per day. So there are three important determinants for uric acid stone formation. It is your low pH, low urine volume, and hyperuricasuria. The most important of the three is low pH. Mostly normal uric acid, but usually low urine pH. So pag may low urine pH ka na, the unassociated form of uric acid predominates. Hence, pwede kang magkaroon ng uric acid stone and or calcium stone formation through heterogeneous nucleation, which I will discuss later. Any disorder leading to a low pH may predispose to stone formation. For example, if you have chronic MET, acid, you have low urine pH, hypocytaturia, and hypercalciuria. Pansin nyo na low urine pH is always sinasabi dito na it's always accompanied with your hypocytaturia. So if you also have insulin resistance, you have impaired ammonium production or excretion that leave hydrogen ions unbuffered in the urine, hence the reduction of urine pH. Acidic urine may also be promoted by increased endogenous acid production or by dietary influences. Next, low urine volume. If you have low urine volume, increased risk ka na magkaroon ng supersaturation. It is seen in populations with warmer climates, as I discussed kanina sa epidemiology. Also, if you have an increased urine intake, most common cause naman dito sa hyperuricasuria. So there would be an increase in urinary monosodium urate, which promotes calcium oxalate crystallization via heterogeneous nucleation or epitaxial crystal growth. So uric acid reduces also the effectiveness of your inhibitors, yung mga TAM horsefall and everything. Also, if you have acquired and hereditary diseases that predispose you to hyperuricasuria are the following: gout, myeloproliferative disorders, polycythemia, etc. So there are types of your hyperuricasuria. First, the congenital, the acquired, the gouty diathesis, and the HUCN. So for the congenital, usually if the patient has a renal tubular urate transport or uric acid metabolism, and also for the acquired, yung chronic diarrhea, myeloproliferative disorders, high animal protein, and uricosuric drugs, and the gouty diathesis and the HUCN. So the first two are self-explanatory naman. Let's talk about gouty diathesis or the idiopathic. Yung mga pasyente nito walang gout, pero mataas yung may hyperuricasuria sila. They normally have a normal uric acid, urinary uric acid, and acidic urine. And usually dito, they also have a low pH. As you may all know that there are no known inhibitors of uric acid crystallization in a pH less than 5.5. So the treatment of choice, alkalinize the urine. Alkalinize the urine by preferably 6 to 6.5. Ang recommendation is do not increase it to 7 because of the risk of calcium phosphate stone formation. Next is your HUCN or your hyperuricosuric calcium oxalate nephrolithiasis. Hyperuricosuric yung patient, pero here, normal lang urine pH. And there's high urinary sodium. If you have high urinary sodium and hyperuricasuria, there will be an increased urinary saturation of sodium urate and calcium oxalate. So the treatment for the hyperuricasuria is allopurinol. The high urinary sodium naman, moderate sodium restriction. And para counterbalance yung hyperuric usura, you also decrease your urine intake and alkalinize the urine. Mind you that even if you have a normal urine pH, maganda to alkalinize the urine. Next is your hypocytlaturia. First, the role of citrate. It's an inhibitor, a very important inhibitor. It complexes with calcium to decrease free calcium. If you have decreased free calcium, decrease na magko-complex niya sa oxalate. It also prevents spontaneous nucleation of calcium oxalate. It inhibits also the agglomeration and sedimentation of calcium oxalate crystals, and it enhances, again, parang synergistic siya with your thumb horsefall glycoprotein. Ang thumb horsefall mo is also a known inhibitor. Also, if there's a chelation of your hydrogen citrate, you also form an alkaline urine. It's also important in the maintenance of normal cellular pH and hydrogen citrate chelation, alkaline urine. Ay, mulit lang pala, sorry. So, it's also an important correctable abnormality if you have hypocytaturia. It's seen in patients with isolated calcium stone formers in 10%. It's also associated with 20 to 60% of stone formers. If you have a low urinary citrate or hypocytaturia, it results to a variety of pathologic states associated with met acid. So if you have metabolic acidosis or low pH, low pH, tama, it predisposes you to a decreased citrate. Decreased citrate, decreased inhibitor effect. Then it favors your stone formation. So the causes are the following. So first is the distal RTA type 1. Tandaan nyo to. It's the only renal tubular acidosis which produces stone. Ang workup nito na usually makikita mo is hypercalciuria, hypocytaturia with increased urinary pH. You can also see hypokalemia and hyperphosphatemia, and the hallmark is inability to acidify urine. It's a consequence of the dysfunction of the alpha type intercalated cells which secrete protons into the urine via the apical hydrogen ATPase pump. It increased distal tubular secretion of hydrogen, resulting to metabolic acidosis. So mapo-form mo dito are calcium phosphate stones. It's also seen in medullary sponge kidney and your nephrocalcinosis. The treatment is potassium citrate. So here is an image of your distal RTA type 1. Note that there's a problem in the acidification of urine as to yung hydrogen hindi makapasok do sa distal tubule. Next also, if you have chronic diarrhea, you will be dehydrated. If you are dehydrated, there will be low urine volume. And then with the diarrhea from the intestines, you lose your intestinal alkali. And then this then leads to acidosis. If you have acidosis, of course, low urine citrate. Low urine citrate, low inhibitor. Low inhibitor, increased complex ng calcium with oxalate. So treatment is potassium citrate in liquid preparation. And also, syempre, you need to treat the cause. Also, it can be seen in your thiazide induced. If you take thiazides, it produces hypokalemia. This hypokalemia causes intracellular acidosis. Hence, acidosis decrease again your citrate. The treatment is potassium citrate supplement to thiazide. So whenever you give thiazide for patients na may tawag dito, hypercalciuria, you should always supplement it with potassium. Kasi pinipredisposed niya magkaroon ka ng hypocytaturia. So, yun. So, if you have high fat load, it decreases citrate and pH. Next, hypomagnesuria. This is rare. If you have magnesium, by the way, is also an inhibitor. So, if you have a low magnesium level, you have reduced inhibitor activity, and also it decreases your urinary citrate levels. Both contribute to stone formation. Next is cystinuria. This is urine production of more than 250 milligrams per day. So, ito, common dito is CoLA amino acid metabolic defect. Yung CoLA, yung cysteine, O, ornithine, L, lysine, and yung A, I think alanine yata. This is autosomal recessive and rare. So, cysteine stone formers, associated daw sila with lower creatinine clearance. Lower the creatinine clearance, prone to CKD. Again, hexagonal crystals sila. Or yun nga, yung tawag dito, tip ko is cysteine 6-hexagon. Okay. It is ESW resistant and usually mga cysteinurics, matitigas yung bato nito. So usually, they undergo open surgical procedures including nephrectomy than their calcium oxalate stone-forming counterparts na PCNL capable yung pwedeng gawin. Matitigas yung stone na to. So for the treatment, of course, if you have the stone, you operate on it. If it's relatively stone, hindi mo na ma-detect unless you do a stone analysis, and then usually operate on the patient. But for the conservative management, high fluid intake, 2.5 to 3 liters per day, so you have a forced urine output of at least mga 2 to 2.5 also. You alkalinize the urine, you avoid salt, and you can give the following: alpha-mercaptopropionil glycine, Thiola. You can also, this is the more superior than the two drugs, dipenicillamine and captopril. It increases cysteine solubility in urine by formation of a more soluble disulfide bond. Next, again, yung image na naman na to, when we operated the patient 2 years ago doing an anatrophic nephrolithotomy, this is an example of your staghorn calculi, or your infectious stones or struvite stones. So in your infection stone, the urinary urea is hydrolyzed to ammonia and carbon dioxide by the presence of bacterial urease. Tatandaan niyo dito, the most common pa rin ng urea-splitting organism is Proteus. Usually tinatanong yan. And then, it then produces alkaline urine by yung alkaline urine promotes hydration of carbon dioxide to carbonic acid, which dissociates HCO3 and hydrogen, further increasing the pH. So usually, ang alkaline pH dito is more than 7.2. Yan yung usually nakikita. Pero 6.5 to 7.0 is noted na itong alkaline pag you're thinking of a staghorn calculi. So the mainstay of treatment for staghorn calculi is surgery. The treatment of choice, of course, is minimally invasive, PCNL. Of course, you need to completely eliminate all the infected stone material. Kasi if you leave something behind, you leave also an infectious stone there. So for the medical, the treatment, again, will be discussed by Dr. Ryan Tuazon on Friday. So for the medical treatment, for the prevention, you can give acetohydromic acid, urease inhibitor, pero usually this is not given because this is associated with significant side effects. This is given to reduce the urinary saturation of your struvite, and no longer uses the chemolysis using hemosiderin solution or renacidin. This is no longer used. So for the miscellaneous stones, let's talk about xanthine stones. Ito, radiolucent to. This is rare and usually confused with uric acid stones. Ang sabi sa research ko, usually this is brick red in color. This is caused by an inherited disorder in the enzyme xanthine dehydrogenase and your xanthine oxidase. Responsible for xanthine is the uric acid, and if you increase your xanthine, you also promote stone formation. So if you give allopurinol also in patients with Lesch-Nyhan diseases, usually they give high doses of allopurinol. Yung allopurinol naman, ini-inhibit niya yung XDH also at saka XO. Hence, predisposed to xanthine stone. So allopurinol as given as overdose or increased amounts can cause xanthine stones. So for your hydroxyadenide stones, usually this is seen in children with adenine phosphorybosyl transferase deficiency. Here, hydroxyadenine stones are extremely insoluble at any pH, and the treatment is allopurinol. So for the ammonium urate stones, this is usually rare. This is seen in developing countries, and this is the most common bladder calculi in children in developing countries. Ang conditions associated dito is yung ileostomy after colectomy. There would be marked reduced urinary volume, pH, and sodium, and prone to ammonium acid urate and uric acid stones rather than calcium oxalate stones. Ito tinanong din sa in-service before, ileostomy patients, usually you develop ammonium urate stones. Also, if you abuse the laxatives, you can cause dehydration from GI fluid loss, causing intracellular acidosis and enhanced ammonia excretion, and urate complexes with abundant ammonia. So treatment, do not abuse your laxatives. So the standard recommendations for patients with ammonium urate stones is increased fluid, oral calcium, alkalinize, and oxalate reduction and salt restriction, and of course your potassium citrate. So for your matrix stones, these are radiolucent stones. Usually, these are mistaken for uric acid stones. Approximately, it's worked parang approximately it's two-thirds mucoprotein and one-third mucopolysaccharide. And this is usually seen in patients with renal failure and on dialysis because proteinuria may contribute to an increased risk of stone formation. So for the medication-related stones, we have two types, the direct and the indirect promoters of stone formation. So for the direct muna, ito, yung antiretroviral agent indinavir. This is ang indinavir for HIV patients is usually eliminated by stool, pero yung kalahati excreted unchanged in the urine. This causes the formation of your indinavir stone, which is radiolucent, and this is the only stone that cannot be seen in CT scan. Stone formation happens when there's a high urinary excretion and poor solubility of the drug. So treatment, you discontinue indinavir, give other antiretroviral agent, you hydrate the patient, and endoscopy for stones that do not pass continuously. For the others, yung mga to, triampyrin daw, guaifenesin, ito yung mga cough syrup, ephedrine in large amounts, at saka silicate can cause also your stones. For the indirect promoter of stone formation, ito yung corticosteroids, again, yung sinabi ko kanina, your vitamin D, PO4 binding antacids can induce hypercalciuria. Thiazides, pag walang potassium citrate na binigay o potassium supplementation, can have intracellular acidosis and subsequent hypocytaturia, and acetazolamide. So ito yung box 52.526 na nakita sa Campbell po lahat. So for the anatomic predisposition of stones, of course, if you have UPJO or uretero-pelvic junction obstruction, obstructed siya, as you can see on the image, there's 20% risk of renal calculi incidence. There's a combination of metabolic and urinary stasis. So if you don't empty, increased stone formation. Like yung sinabi before ni Dr. Abram, yung tawag dito, if it's super saturated, if there's ion trapping, if there's alteration of urinary pH, and if there's loss of inhibitors, increased risk of your stone formation. So this happens here. If you have stasis and of your urine, increased risk kan magkaroon ng stones. So again, you should distinguish a UPJO. If the UPJO is caused by a renal stone formation or renal pelvis, or a UPJ stone provoked by edema, giving a misleading appearance of your UPJO. So you can do a CT scan or a Whittaker test. And you should always ascertain renal function before doing any intervention. For horseshoe kidneys, 20% din ang renal calculi incidence dito. Here kasi, there's high incidence of your ureter in the renal pelvis. Pag high insertion, impaired ang renal drainage. So para ka rin may UPJO. Most common renal fusion anomaly ang horseshoe kidneys, and is usually seen male to female ratio is 2:1. Here naman, as compared to UPJO, mas grave ang metabolic abnormality than the stasis pathology, but the two still works, this hand on hand, para magkaroon ng stone. So usually, there's an abnormal medial fusion of the left and right metanephric blastema with isthmus that anchors in the level of the IMA, or inferior mesenteric artery. There's an incomplete renal ascent and malrotation and high insertion of the ureter to the pelvis. This impedes drainage and promotes stasis. And usually it's situated below the 12 rib, and most common stone dito is calcium oxalate. So here is an image of your horseshoe kidneys. So calyceal diverticula, 40% stone risk, combination of metabolic abnormalities and urinary stasis like your UPJO, mainly calcium oxalate monohydrate stones, and can also have struvite carbonate apatite owning to an infectious component. If there's concomitant UTI, which is found in 40% of cases, pwede ka rin magkaroon ng struvite component ng calyceal diverticula. But between the two, ang most common pa rin na stone na form sa calyceal diverticula is your Ca-ox monohydrate. So here is an example of your calyceal diverticula complicated by a middle pole or calyceal stone na nasa middle pole. So ang location usually ng calyceal diverticula mo is 50% upper pole, then 30% mid pole renal pelvis, 20% lower pole. Next, MSK, medullary sponge kidney. Ito, common naman dito, yung nephrocalcinosis and renal calculi. There's recurrent infection in urinary stasis within the ectatic tubules pose a risk for stone formation and may be associated with distal renal tubular acidosis. There's hypocalciuria and hypocytaturia as contributing factors. So here, and this is an example of your medullary sponge kidney. So next, let's talk about workup. Abbreviated protocol for low-risk stone formers. You have the extensive evaluation and the simplified evaluation. For the extensive evaluation, the 24-hour urine collection. So you collect the urine, usually you discard the first urine, and then you collect the urine until the next day. And then after 24 hours, dapat nakastore siya into a ref or maybe may preservatives, and then you evaluate on it. So ang sabi dito, no consensus regarding the need for 1 versus 2 24-hour urine collection. Although, prefer ng mga urologists are 2 random collections. So, in the abbreviated evaluation of single stone formers, of course, you need to know first the history. Know the underlying predisposing conditions. For example, dry, hot, arid ba siya? Low ba yung tawag dito, yung intake niya ng fluid? Mahilig ba siya sa salt? High purine diet pa? You also ask about the medications. If there's increased calcium, vitamin C, Hyperox A Urea, right? And then vitamin D, hypercalciuria, and the others. For dietary excess, inadequate fluid intake, and the following. You also then, after the history, kuha mo ng dugo, you get the metabolic panel, you know the levels of each in the blood, the calcium, and here they also analyze the intact parathyroid hormone because yung PTH nga, again, also, there's an increase in the PTH, pwede ka magkaroon ng hypercalciuria din. And also for the urine, you analyze, of course, the most importantly is the pH. Pag more than 7.5, infection lithiasis, and less than 5.5, uric acid lithiasis. And for the sediments also, you check for the crystals, and you also do your urine culture and qualitative cysteine. And of course, you need to do imaging to know if it's radiopaque, radiolucent. And of course, if you have the stone already, you do your stone analysis. So for the simplified evaluation is the development of urine preservation that allows without collection of urine without refrigeration. So ito yung ina-assign nila mga profile. So for the conservative management, a fluid recommendation is to increase your fluid intake to have a daily urine output of at least 2 liters. So we usually advise the patient to drink 2.5 to 3 liters of water to have a forced urine output of 2 liters. Water hardness daw, little effect on clinical outcome to. Pag carbonated drinks like your Coke or Sprite, carbonated water increases protection daw against recurrent stone formation as compared to still water. Still, ito, tinanong before, no, first year ako, is your citrus juices. If you drink lemonade or orange juice adjunct to water, increase daw ang citrate nito. It provides increased also urinary volume, so protective siya. So for the diet recommendations, protein restriction. So renal stones with higher, with increased animal protein intake. So protein intake increases urinary calcium, oxalate, and uric acid excretion. And diet in fruits and vegetables and low in animal protein, especially DASH diet, is associated with reduced risk of stone formation. Pag sodium restriction naman, ang net effect nito sa high sodium diet was an increased propensity for the crystallization of calcium in the urine. When combined with animal protein restriction and moderate calcium ingestion, a reduced sodium diet will decrease stone episodes by roughly 50%. Obesity. If you're obese, increased BMI, larger weight, weight gain, correlated ng increased risk for stone episodes. At saka, mahirap operahan ng pasyente mataba. And the next, hindi rin ito madaling i-shockwave. Metabolic syndrome, cluster of disease. So lahat ito nagdi-decrease ng pH. If you have low urine pH, again, increased risk ka magkaroon ng uric acid stone, hypocytaturia, pwede ka magkaroon ng calcium oxalate, ang dami. So you need to treat the metabolic syndrome. So most common stone composition was calcium oxalate, but significantly higher risk of having uric acid stone. Uric acid stone formation in obese may be secondary to production of more acidic urine than non-obese. Weight loss diet. So if you do a low carb, high protein, keto, there's marked acid load to the kidney and increased risk of stone formation. Pag bariatric surgery naman, nag-Roux-en-Y, significantly increased the over risk of stone formation. So the role of dietary calcium, sinusupport ngayon ng consensus is that you maintain a moderate calcium intake, not necessarily restricted. So limitation of dietary calcium may subsequently increase oxalate absorption. Pag in-increase mo naman, kung hindi ka na masyado nag-take ng calcium, pwedeng mag-increase ng oxalate, marami magsasaturate with oxalate, forming calcium oxalate. And then for your calcium citrate, ito yung supplement, more stone-friendly daw to than na mga sa ibang calcium supplements. So may additional inhibitory effect kasi dito ang calcium citrate. So if you prescribe your calcium with patients with stones, maganda calcium citrate ang ibigay than yung calcium carbonate. Oxalate avoidance. So restricted oxalate for recurrent nephritis and low oxalate for enteric Hyperox A Urea, underlying bowel abnormalities, or if the patient is status post-gastric bypass surgery. So you give low oxalate dapat sa patients. And of course, if heavy dosing, like ang dosing dapat ng vitamin C mo is isang tableta lang. Kasi pag dalawa, 2 grams na yon. If heavy dosing, increase your hyperoxaluria. Increase intake, oxalate conversion kasi siya. So for the diagnostic evaluation of acute stone episode, so may dumating sa ER, evaluate my patient, history, PE, blood chem, CBC, BUN, CRE, and the likes. You also do your PT, PTT, and then you'd also do your radiologic imaging. Ang usually ginagamit dito, standard for diagnosing of acute flank pain is non-contrast CT or your CT stonogram. In cases na stone removal is planned, pwede ka magawa ng contrast study on the patient. The role of ultrasound naman, it's safe, no risk of radiation, reproducible and inexpensive, and the following sensitivity and specificity, 94% specific for ureteral stones and 88% specific for renal stones. And role of KUB X-ray, usually ginagamit to in conjunction with your ultrasound to know between radiolucent radiopaque stones and used for comparison during follow-up. And for the special considerations, pag pregnant yung pasyente na may acute stone episode, you consider first ultrasound, lalo na kung nasa first or second trimester ng pregnancy yan. Second line mo dito is MRI. And then low-dose CT ang last option, then limited IVT. Pag sa children naman, you do your ultrasound as first line and KUB or low-dose NCCT or non-contrast CT as an alternative if ultrasound will not provide required information using the ALARA protocol. So for the miscellaneous scenarios, ito na yung few slides na lang. Bladder calculi. Bladder stones are usually composed of uric acid in non-infected urine and struvites in infected urine. And treatment, of course, is to relieve the bladder outlet obstruction. Endoscopic ang approach natin, lalo na kung sa bata, for cystolithotripsy, or kung sa matanda, you remove it cystoscopically by laser. You can also do the oral-nasal irrigation to the suprapubic catheter and IFC to prevent incrustation. So for your neonatal nephrolithiasis naman, usually this is furosemide-induced nephrolithiasis. Usually patient may hematuria, worsening renal function, calcific densities on ultrasound, and nephrocalcinosis are seen on imaging. For diagnosis, screen neonates do diuretics. So pwede mong i-ultrasound yung patient. Or for the treatment, you stop the furosemide and use thiazides. So for the children and adolescents naman, screen for inherited genetic disorders katulad ng cystinuria, yung COLA, deficiency, distal RTA type 1, or primary hyperoxaluria if present, yung meron kang type 1 AGT deficiency. So you need to collect 24 hours of urine and know the calcium creatinine ratio. The treatment is same as adults as well as dietary recommendations. For the stones in pregnancy, common to kasi there's physiologic hydronephrosis seen in 90% of pregnant women. It can persist 4 to 6 weeks postpartum, and the cause nito ng physiologic hydronephrosis is the effect of progesterone and the compression of the ureters compression of the ureters by the gravid uterus. Typically, mas grabe makikita to sa right than the left as a result of engorged uterine vein and the rotation of the enlarged uterus, and this promotes stasis and increased renal pelvic pressure and increased risk ng stone. Ang renal blood flow mo rin is 30 to 50% rise sa glomerular filtration rate. So kung marami kang nafi-filter sa kidney mo, dadami din mafi-filtered mo ng mga crystals or mga solutes like yung calcium, sodium, and uric acid, leading to hypercalciuria and hyperuricosuriia. And your vitamin D is also produced by placenta. So if there's an increased vitamin D, intestinal ang effect nito, increased intestinal absorption. Pero mind you, if you do have these lithogenic changes during pregnancy, but note that an overall risk of stone formation has been reported to be similar in gravid and non-gravid women. So thank you. That's all. Management will be discussed by Dr. Ryan Tuason, mga PCNL, URS. Reserve your questions for Dr. Tuason. That's all. Thank you.
Thank you, Dr. Sergio, for that very, very detailed discussion. So do we have questions from our panel? Yes, sir.
Sid,
Sir.
how are you?
Sir, good evening, sir. Okay naman, sir.
I was trying to hear from you. I don't know if you are the right person to answer this or Ryan, because it pertains to management. Anyway, the so-called recurrence rate after the patient has been declared as stone-free, so you know the recurrence rate, whether it's medical, surgical, whatever, patient has been declared as stone-free. Stone-free.
Yes, sir.
By your patient, the recurrence rate.
50% in 10 years, sir. Risk of stone, sir.
Generally. But it depends on the cause of the stone. If the cause of the stone is structural, like infundibular stenosis, UPG obstruction, urethral stenosis, or stricture, recurrence rate is, of course, 0 after treating the cause of the stone.
Yes, sir.
You got it?
Yes, sir. If you treat the cause, the main cause, the abnormality.
Well, anyway, I was trying to hear from you things like, you mentioned extensively on the urinary citrate, urinary magnesium level, oxalate, etc. Unfortunately, in our clinical practice, very few are asking for this. And some laboratories, including veterans, I think, they don't have urinary citrate determination.
Yes,
urinary. This, when I was there, but negative result. To highlight on this, that's very, very important, because we are very fond of giving potassium citrate, etc., after a patient has been declared free. Next question is, for how long are you going to give this medication? How would you monitor the patient recurrence or not? Whether you stop medication? Ryan yata sasagot dito eh.
Yes, sir. Next Friday, sir, di-discuss niya, sir, yun.
Will be... Do you want to advance your answer, Dr. Tuason, if you're available? How should you give your potassium citrate?
Well, the question is, it's very, very, very popular medication in our practice. After PCNL, after shockwave, after open surgery, you start giving potassium citrate. And another thing is, why potassium citrate and not sodium citrate preparation?
Ray, na-mute yata si... Sir, I think you muted your phone, sir. Naka-mute kayo, sir.
Sir, naka-mute kayo, sir.
Sa bottom right, sir. Sir, sa bottom right po, sir. Try niyo po sa left.
Yung host,
Yung
pwede
ano,
siya
sir, yung mic
i-unmute.
na button.
Yung host, pwede siya i-unmute.
Ray, nandiyan ka ba?
Ray.
Nag-hear yata si Ray.
Nakatulog yata. Ray.
Tawagan natin. So while waiting for Dr. Tuason, do we have other questions? Sir, try niyo po i-figure out yung unmute, sir. Sa bottom right or left. Si Ray, ba't meron? Hindi ko makakani.
Hello?
Yan, sir.
Ayan, sir. Yan. Ay, na-mute ulit.
Sir, okay na kanina. Kung ano man yung...
Baka na-press nyo lang sandali, sir. Press nyo siguro ulit.
Ayun. Okay na, sir. Ayan. Ay, wait.
Okay na.
Ayan, sir. Okay,
Yan,
okay.
yan, sir. Okay na. Yan, sir. Okay na.
You got my question ba? Hindi ko na rin matandaan eh.
For how long we give...
The potassium citrate is very popular among us. Correct?
Yes,
Yes, sir.
Now the question is, what are the indications? Why not sodium citrate? Why potassium citrate? And how long do you give this? There are preparation of sodium citrate.
Who wants to answer that? Ernest, do you want to answer that question?
Usually, sir, we give it, sir, for 3 to 4 months, sir.
Which one? Potassium or
potassium
sodium?
citrate, sir.
Why that long? And how would you monitor that? When to stop it? When to give it after 3 months, after a month? I hear so many answers on that. Other clinicians give that indefinitely to prevent recurrence. What do you monitor when you give that medication?
We monitor, sir, by imaging, sir, by ultrasound, QV ultrasound repeat after 3 months, sir, to check if there's still presence of stone, sir.
And then about biochemically, what do you monitor? Ayan.
Ras, do you have an answer for that?
Sir, aside from monitoring your stone, you also monitor, for example, if you're giving your potassium citrate, you should also do serial monitoring of your serum potassium to go with your ultrasound.
Serum
Yes,
potassium.
Yes, sir. To check if the patient is developing hyper K because of your treatment.
What is the role of hyperpotassium in stone formation?
No, sir.
It's
I
the
mean,
site. It's the
yes, sir.
citrate. It's the urinary
Yes, sir.
citrate.
Yes, sir. Yes,
And
sir.
that I mentioned earlier. Unfortunately, our laboratory
They don't have the
does.
urinary cycle.
Yeah,
Yes, sir.
yeah,
Yes,
yeah.
sir.
I think you ask Edipol or Fred to check on our laboratory when do we have that basic information to
Yes,
monitor
sir.
our stone disease. Another thing is urinary pH. At what level of urinary pH does the uric acid stone liquefy? Or you keep you keep it in solution at what urinary pH? Uric acid stone. Do you know that?
7.
Sir, I discussed it a while ago, sir.
Yes, sir.
You predispose uric acid stone if the pH is less than 5.5. So what you need to do is alkalinize the urine between 5.5 to 6, sir. Because if to 6.5, because if you alkalinize more than 7, increases naman ng calcium phosphate stone, sir.
Correct. Actually, it's in textbook perhaps 6, but it's 6.5 to 6.8. You keep the urine in solution at that level.
Yes, sir.
If you increase that level, you will invite another stone formation, infection stone perhaps. So you monitor these things. Unfortunately, again, wala tayong urinary citrate.